All right, so I wanted to engage in a little bit of futurism, and what better way to start off with the futurism than to start with Star Trek. Star Trek has a lot of lessons to teach us about futurism, so let's start with the Enterprise. If you don't know what Star Trek is, this is going to be a very boring talk for you. You're just lucky I didn't bring my Spock ears. So the Enterprise is a marvel of 25th century technology. It's got this replicator, which allows them to kind of make any food they want, including whatever was in that tea. It has a teleporter, which allows them to deconstruct atom by atom a person, reconstruct them somewhere else, and their consciousness goes with them. It even has time travel. Now, this is what the futurists in the 70s, 80s, 90s were thinking about when they were thinking about what will technology allow us to do. But perhaps what's most interesting is what they thought about when they thought about the cockpit of the Enterprise. Now, there's an interesting thing about the cockpit here, which I don't know if many of you noticed this, but let me zoom in and show you something funny about it. Despite all of these marvels, the Enterprise needed to be driven. Not by one guy, but by two guys. They couldn't even imagine a self-driving Enterprise. Now, that is at the heart of everything that I think is hard about futurism. You're either just talking about what's right in front of you, or you're not looking around the corner, you're pretending like corners don't exist. Like we pretend the laws of time travel, whatever, time travel, that's possible. But by not recognizing there are limits and constraints, we don't see the technologies that are transformative that are around the corner. So what I want to do is to talk a little bit about at least one guess, and everyone just has a guess, my guess on one thing that's around the corner for AI in medicine. And to do that, I'm going to talk about one or two particular projects where we already have data coming in, which to me illustrate a kind of computational medicine that I think we can do. The first project I want to talk about is about knee pain. Many people go into, older people go into the hospital complaining of knee pain, and of course we suspect they may have osteoarthritis. We're curious how severe the osteoarthritis is. We have some treatments we can bring to bear, but to figure all this out, we do an X-ray. Now that X-ray is given to a clinician who produces, for example, a KL grade, some estimate of how bad is this osteoarthritis by looking at it. Now, in the current rendition of what most of you are probably thinking, you say, oh, well, this is a perfect job for algorithms. So instead of having the clinician do it, let's have the clinician label the data, and let's build an algorithm that can look at an X-ray and do what the clinician would do. This is, I think, the playbook that is developing right now in computational medicine. Obviously, it's not just X-rays. It's let's take clinical judgment of some image modality, and let's do this with MRIs, with EKGs, with CT scans, diabetic retinopathy, and there's a lot of work going here. This is the automation playbook. What I want to talk about is, I think this is a reasonable approach, and we're seeing a lot of it, but ultimately, I think this is seeing what's in front of us and not looking around the corner. I think there's something more transformative that can be done. So to do that, let me go back to, I should say, this is why I think a lot of people think the end of radiologist is coming in front of us, because we'll be able to automate all this. I will say that I send this to my mom every day, because she wanted me to be a real doctor. But I guess you already knew that, seeing as how I was Indian. Now, this is, let's go back to this. There's an interesting fact about osteoarthritis that I want to tell you about, which is a little troubling. If we look at the incidence of pain in the United States, we find that, in fact, African Americans and whites experience pain differently. Actually, it's not just African Americans and whites. It's rich people and poor people experience pain differently. One fact about poverty in the United States is that the poor live in greater pain. Now, you could say, well, they probably just have worse degeneration. Here's the interesting thing. If I put on the x-axis, this is a large sample data set, I put on the x-axis severity and I put on the y-axis the racial gap in pain, what you actually find is at every level of severity in the knee, the poor feel more pain. We might call this, it's not in their knees, it's in their heads hypothesis. Something about poverty magnifies the physical experience of pain. This is why, if you look in the data, African Americans are more likely, conditional on severity, to be given opiates, and whites are more likely to be given knee replacements. It's just the nature of, we believe it's more in their heads than in their pain. But is this true? Maybe it's not. Maybe it's not in their heads. After all, who's doing the reading of the X-ray? It's a human mind with limited clinical knowledge. We only started reading X-rays not that long ago. So what if we went back to this playbook and said, why are we trying to replicate what the human mind knows? Why don't we try to look into these puzzles and see if we can find something new? How would we do that? Well, we would simply train the algorithm not to predict what the clinician knew, but to predict the pain. Notice if the pain were just in the head, there's nothing to predict here. Well, what do we find? After all, the algorithm can only look at the knee. That's all we're giving it. We're just giving it the X-ray. Well, what do we find here? This was the gap by clinician judgment. In our data, when we train an algorithm to do this, we find the pain gap completely disappears. In fact, it is not in their heads. It is in their knees. And we've been under-treating genuine osteoarthritis in blacks. And in fact, the algorithm saw something that we couldn't, heard something that we didn't. Think of how crazy it is that people are coming in and saying, I have a lot of pain, and we were saying, yeah, must be in your head. If it was a rash, if it was a physical ailment, we wouldn't say it's just psychosomatic, you should take some painkillers. But we converted our limited knowledge and pretended like it was our full knowledge. And this is what I want to talk about here is automation versus discovery. And I think we have the ability to discover fundamental truths, and these algorithms do that by letting us look at data in a different way. I thought the Jon Snow example was exactly right. This is simply looking at data and discovering things like the pump. How do we discover more things like the Broad Street pump? Well, now we can look at very high-dimensional images in a way that we couldn't before. Let me tell you one quick thing, and then we'll get to... So this is in cardiology. Someone comes in complaining of chest pain. One of the things that we have to do is decide whether they're having a heart attack. Of course, if we know that they're having a heart attack, there are things we can do. The consequences of a scar from a heart attack are quite fatal, but luckily we can do stenting, emergency stenting. Of course, the problem is that it may not be a heart attack. It may actually be Indian food you ate yesterday and may just be heartburn. This poses a clinical problem that many clinicians struggle with. How do I decide whether a person is having a heart attack or simply some other competing diagnosis? We have stress tests, we have catheterization, we have things we can do. But of course, these are expensive. I can't stress test and catheterize everybody. So what can we do? Well, we could take the EKG and a bunch of other modalities and have the physician decide how to test. Or we could train an algorithm. Now notice, comes the key point. What do we train the algorithm on? We don't want to test the people the physician would have tested. We don't want to automate that choice. Well, why don't we train them on, will the test find anything? Let's use that to rank people. When we do that, here's what we actually find. This is in a large data set of a few million people. On the x-axis, I put the algorithm's prediction of test yield, and on the y-axis, I put the return on testing. And what you can see is amongst the people we're testing, there's actually a huge variation in return. In the bottom end, we are ridiculously over-testing. The value of a DALI down here is about $450,000. This isn't really truly wasted tests. In fact, we can find significant fractions where out to a few decimals, there's zero chance of finding anything. We can drop about 51% of all tests by having the algorithm rank. So that's fine. We know there's a bunch of over-testing. But let me tell you what I found really interesting here. The top decile of the cost distribution is very cost-effective. The problem, over 50% of these people go untested. So in the system, we not only are having a huge amount of over-testing, we've got noticeable under-testing. When we follow this population over time, they go on to have massive cardiac events in the next 30 days at pretty high rates. What this means is that we both over and under-test. And in fact, what we should do is cut these tests and add these tests. So if we use an algorithm to rank these populations, we both are able to cut costs now, cut future costs, and save more lives. Simply because the human mind's ability to convert the EKG and other modalities into the prediction of what's going to do is not great. So there's both lives and dollars on the table. It's like, I think, a new, better drug. So let me just illustrate what I think is the difference between automation and discovery. I think automation uses data produced by health systems. Good news, so does discovery. But that's where the paths differ. Discovery is trained on ground truth, whereas automation trains on clinical judgments. We're simply trying to replicate. Automation is nice because problem formulation is easy. Hey, here's an x-ray. Here's what the radiologist said. Replicate that. Discovery is complicated. It requires very careful formulations of the problem, and I can talk about that offline if people are interested. in the interest of time, let me do this. What's really the big difference in my mind is the team that's needed. In the automation work, I think a really good CS team with a little clinical knowledge added can really do a good job. We're finding when we do discovery, we need teams of bilingual people, people who can both speak a little medicine and a little computer science. So, but the big difference I think here is the upside. You're going to save some clinician costs in automation, but discovery allows us to have fundamentally new breakthroughs where we bend the curve. All right. Let me just go through some other examples of discoveries, and I'll stop. We've been doing some work on opiate abuse. How do you figure out if someone is there? It turns out the EKG has signal for whether someone has actually currently got opiates in the system. We're starting some work on x-rays and trying to model bone fractures. We are thinking Alzheimer's. There's actually data in handwriting for the onset of Alzheimer's, which is an interesting, very different data source. Let me conclude on this. Here's Apple's supply chain. Lots of suppliers. Who makes all the money? Most of the employees sit in the supply chain. Most of the money goes to Apple. It's an obvious fact. You don't want to be the supplier to a monopolist. How do we think health is going to shake out? Whether you think it's IBM Watson, whether you think it's Google Health, whether you think it's somebody else. It looks like the health systems are the suppliers to these data companies. Who do you think is going to hold the cards? Oh. What I want to talk about is the data supply chain creates very uneven market power, but monopoly is not inevitable. There's diminishing returns in data size after critical mass, and I think right now what I'd like to do is assemble a set of committed partners to do radical innovation, because I don't think we should be sitting in a world where we contribute data to big pools, but instead should have small pools, and that's more than enough to do the discovery that we need. So let me stop there. Thank you.